Mr. Yellowback?
No, Rick, I was thinking about that. You said a while ago in your statement that 1332 waiver was in the individual mandate.
Yes, sir, that's correct.
Did that just take completely soon, or I mean, was that just redone? Because I asked this question. We have a report from for public consulting group on page 21. It says individual mandate 1501. At this time, a waiver to the individual mandate is not applicable.
So the individual mandate waiver would not take effect until the waiver itself took effect. Therefore, it wouldn't take effect until 2017. So it would be accurate to say at this point in time there is no waiver. That's correct. So yes, sir. You have to have a successful waiver that was approved by the administration, and then it could take effect, but not until January 1 of 17. The third requirement, we talked about comprehensiveness, we talked about affordability. The third requirement is what I call a breadth requirement. And that basically says that the waiver has to provide coverage to a comparable number of people as the ACA would. Now, it's interesting here to note, the law doesn't say it has to provide coverage to the same people. It just says to a comparable number of people. So presumably, you could devise a reform plan that covered the same number of people, but a slightly different population from what the ACA may have intended. Finally, and this is probably a piece that is most important to you as you think about the mechanics of this, the 1332 waiver may not increase the federal deficit within the 10-year budgetary window. So just to provide a point of contrast, the 1115 waiver requires budget neutrality with respect to Medicaid dollars. The 1332 waiver is broader than that. It requires budget neutrality with respect to the entirety of the health reform plan, thinking about the entirety of that health reform plan also at the federal level. And so the budget neutrality requirements in 1115 and 1332 are slightly different. And 1332 arguably gives states a little bit more budgetary flexibility because dollars can be shifted between programs, between Medicaid, between some sort of a subsidy program for commercial insurance that was intended to target folks that were buying coverage through the exchanges, for example.